This is Spencer, and in this video we're going to talk about the physiology of the lungs and the chest wall. Let's start by talking about the mechanics of breathing, specifically those that rely on the lung's compliance, or how well the lung can change volume in response to a certain change in pressure. Think about your lungs with high compliance as flexible and able to quote-unquote go with the flow, and those with low compliance as inflexible and stiff. This graph represents the pressure dynamics between the two systems of the lungs and the chest wall. The blue line represents the chest wall force. The red line represents the lung force, and the green line represents the sum of those two pressures. It may not be intuitive at first, but what you are seeing is a fancy graphical representation of two opposing forces or a constant tug-of-war going on inside your chest at all times. The lungs pull inward, whereas the chest wall pulls outward. If you look at the x-axis and move right, you are going up in pressure. This increase in pressure has a linear relationship with lung volumes, which is the y-axis. So as the pressure increases inside the lung volumes will also increase. When airway and alveolar pressures are at 0 on the x-axis, this corresponds to atmospheric pressure, and the volume of the lungs will not be changing. The measurement used to describe this state is the FRC, which stands for functional residual capacity. As in any system with opposing forces, this is your equilibrium. So, at atmospheric pressure, the chest wall's force is, again, described as an outward pull on the lung tissue. So the chest wall has a tendency to naturally expand, or grow in diameter, in an anterior or posterior direction. But there's something that is opposing that expanding force, which is, the lungs. What's one disease process that might cause a type of chest hyperexpansion if the lungs weren't functioning properly? Emphysema. In emphysema, there is an increase in the AP, or anterior-posterior diameter of the chest wall, because there is an actual destruction of the lung tissue. The chest wall's outward pull is left relatively unopposed. So when the pull or inward force of the lungs is decreased, the chest wall wins out, causing the increased chest wall diameter. What's the nickname used to describe these patients with emphysema? Pink puffers. On the other hand, you need to remember the lungs have a natural tendency to collapse or create an inward pull on the chest wall. If the inward pull of the lungs was unopposed, what would that create? A pneumothorax. The lung would collapse on itself if the chest wall's outward pull wasn't there to equalize the lung's natural tendency to collapse in on itself. So to review, when you're breathing, there's a tendency for the lungs to collapse inward and the chest wall to spring outward or expand outward. When the lungs are at their functional residual capacity, the inward pull of the lung is equal and opposite to the outward pull of the chest, which you can see here again. The system pressure is the same as atmospheric pressure at this point, and there is no net air movement. At this point, the airway and alveolar pressure are both 0, and the intrapleural pressure is negative. By the way, why is it negative? Negative intrapleural pressure helps keep the airway open. This prevents atelectasis, also known as alveolar collapse. This directly ties in with the concept of compliance that we've been mentioning. Compliance is defined as the change in lung volume for a given change in pressure. So higher compliance means that the same pressure change will create a larger volume change. What's the inverse of compliant? That would be stiff. The slope here is a measure of compliance. As you can see here, where the slope is steep, you have the most compliance. You tend to have more stiffness or less compliance at extreme volumes, and therefore you see a flatter curve at either end. When compliance is high, the lungs are easier to fill with air, as seen in emphysema or in a normal aging process. The lungs have lower compliance and thus are harder to fill in conditions like pulmonary fibrosis, pneumonia, NRDS, and pulmonary edema. As we've learned previously, surfactant is produced by the type 2 pneumocytes, which indirectly helps increase lung compliance by keeping surface tension low and thus collapsing pressure low of the alveoli. Hysteresis is when the lung inflation curve follows a different curve than the lung deflation curve due to the need to overcome surface tension forces during inhalation. So let's use a clinical example to review the concept of compliance. If you have a patient in your ICU who requires ventilator support for adult respiratory distress syndrome, or ARDS, let's use a clinical example to review the concept of compliance. If you have a patient in your ICU who requires ventilator support for acute respiratory distress syndrome, or ARDS, will you typically need higher or lower positive airway pressures to ventilate their lungs? Well, let's break it down a little bit. In ARDS, you have pulmonary edema, which makes the lungs stiff and non-compliant. The same is true in restrictive lung disease. So think restrictive, stiff, and less compliant. Lower compliance means there's a smaller change in volume for a given pressure. That means you're going to see you need more positive airway pressure to get the same tidal volume, and you'll see a flatter volume pressure curve. Clinically, the amount of positive pressure can be so high that it may actually cause trauma to the lungs, which is actually known as barotrauma. Baro meaning pressure. Let's do a little flash quiz. The lungs tend to collapse inward, expand outward, and the chest wall tends to collapse inward or expand outward. Right. The lungs tend to collapse inward and the chest wall tends to expand outward. Hey, this is Spencer, and in this video we're going to talk about hemoglobin, which is really high yield for your boards. Hemoglobin literally means blood ball or sphere. So you can see this polypeptide kind of looks like a little ball. Adult hemoglobin is a polypeptide comprised of 2 alpha and 2 beta subunits. There's a top form of hemoglobin, which has a low affinity for oxygen on the heme molecule. And there's a relaxed form, with almost 300 times greater affinity for oxygen. Does carbon dioxide bind to heme itself? No, it binds to other parts of the hemoglobin protein to form carbaminohemoglobin. Carbon monoxide, on the other hand, does competitively bind at the same heme site to form carboxyhemoglobin. An important concept to understand when looking at hemoglobin is positive cooperativity. So what is positive cooperativity? The binding of the first oxygen molecule pushes the hemoglobin into the R, or relaxed state, by tugging on the histidine residue. This makes it easier for oxygen to bind to the other 3 heme groups. The only time hemoglobin is in the taut state is when no oxygen is bound. It is in the relaxed state when 1 to 4 oxygen molecules are bound to hemoglobin. This explains the sigmoidal nature of the oxygen-hemoglobin dissociation curve, which I'll show you in a little bit. Negative allostery occurs when something like 2,3-BPG binds to hemoglobin, stabilizing the top form and reducing hemoglobin's affinity for oxygen. Do you recall when humans physiologically produce more 2,3-BPG? One example is at high altitudes. Why does this make sense? Because in conditions of low oxygen tension, the hemoglobin must release oxygen more readily in the tissues. 2,3-BPG binds more hemoglobin and allows more oxygen to be delivered to peripheral tissues, where oxygen is needed most. Do you remember another major kind of hemoglobin seen in development? Right, fetal hemoglobin. And how is fetal hemoglobin different than adult hemoglobin? It's comprised of 2 alpha and 2 gamma subunits. Which type of hemoglobin, adult or fetal, has a higher oxygen affinity? Fetal. This allows fetal hemoglobin to pull oxygen from across the placenta and essentially steal it from mom. Think of fetal hemoglobin as a little ingredient. Each hemoglobin subunit has a non-protein heme group containing a single iron atom. This iron atom forms a strong covalent bond to a histidine residue in the globin chain. Now, a quick word about fetal hemoglobin. Here's the normal adult hemoglobin saturation curve, which is sigmoidal due to, right, positive cooperativity. After the first oxygen binds, the hemoglobin becomes relaxed, and so the next 3 bind really quickly. which is why you see a rapid rise in the curve as the oxygen saturation goes up. Fetal hemoglobin is composed of what again? Right, 2 alpha and 2 gamma subunits, rather than 2 beta subunits from adult hemoglobin. Fetal hemoglobin has a higher affinity for oxygen than adult hemoglobin. Here you can see the difference in oxygen saturation curves, with the fetal hemoglobin curve being shifted to the left. What makes fetal hemoglobin's affinity so high for oxygen? Well, 2,3-BPG binds hemoglobin in order to decrease hemoglobin's affinity for oxygen, which then increases oxygen delivered to the tissue, like we discussed. Fetal hemoglobin actually has a decreased affinity for 2,3-BPG, so its affinity for oxygen is thus much higher, because we want the fetus to have as much oxygen as possible that it can get from mom's blood. Finally, fetal hemoglobin will make up nearly 100% of the total hemoglobin from about week 10 until birth. You can see the alpha and gamma subunits are highest during this period. However, after birth, the fetal hemoglobin concentration will start to decrease and be replaced by adult hemoglobin. Notice that the gamma subunit is decreasing over time as the beta subunit increases. This transition takes about 6 months total. So here's a bonus question. Sickle cell disease is treated with hydroxyurea for what desired effect? It turns out that hydroxyurea increases the level of fetal hemoglobin in the blood, and this reduces the number of painful episodes. Hey, this is Spencer, and in this video we're going to talk about the oxygen-hemoglobin dissociation curve. This is another high-yield concept that you'll see on your boards. You recall from our discussion of hemoglobin that the binding and unloading of oxygen from hemoglobin shows positive cooperativity, meaning the affinity for oxygen increases as each site is filled, thus resulting in a sigmoidal shape of the curve. So how does this compare to myoglobin? Well, myoglobin is a monomeric heme protein similar to the alpha subunit of hemoglobin. It's monomeric instead of hemoglobin's multimer, and is not capable of having those cooperative allosteric interactions, because there aren't really things with which it could cooperate. It's only one subunit. So as you see here, myoglobin has a hyperbolic, non-sigmoidal curve, where it has a greater affinity for oxygen than hemoglobin. Interestingly, the hemoglobin curve can shift right or left under specific conditions. So why would the curve shift, and why does that matter clinically? A shift in the curve in any direction simply means that there is a change in the affinity of hemoglobin for oxygen. A shift to the right signifies a decreased affinity for hemoglobin for oxygen, meaning the oxygen is more likely to be unloaded at tissues. This is a right shift curve. Think for a moment about situations where this would be helpful. For example, when you're exercising, your muscles need more oxygen, so it makes sense that the curve shifts to the right, meaning hemoglobin at the same pressure of oxygen in the atmosphere will be less saturated since oxygen is being unloaded in the tissue. So a number of factors will shift the curve to the right. A mnemonic to keep in mind is ACE-BAT right-handed. Acid, CO2, exercise, 2,3-BPG, altitude, and temperature. What do all these factors have in common? So these are all states where there is a need for more oxygen delivery to the tissues, and they all stabilize the top form of hemoglobin over the relaxed form. This allows hemoglobin to better unload the oxygen at the tissues. So this makes sense, right? Active muscles, like during exercise, locally cause an increase in local temperature, CO2, and increased acidity. 2,3-BPG is synthesized in red blood cells from 1,3-BPG as well. Do you recall where else you may have learned about 1,3-BPG? So 1,3-BPG is an intermediate in glycolysis, which you can learn more about in the biochem chapter. Besides being at high altitude, when does the body make more 2,3-BPG? You usually see more 2,3-BPG when there's tissue hypoxia, as in COPD, which we'll discuss in another video, and CHF, which we'll discuss in greater detail in the cardiology section. Not surprisingly, if you decrease any of these factors, you can get a left shift of the curve, which means increased affinity of hemoglobin for oxygen. This means hemoglobin is going to hold on to oxygen more tightly. Think of a lower amount of these factors means the curve is shifting left. Alternatively, you can just think of it as ACE-BAS right-handed, and if the patient is in the opposite physiologic state. A good example of a left shifted curve is the fetal hemoglobin curve, because it has a higher affinity for oxygen than adult hemoglobin. Why is this important? The fetus needs to steal oxygen from mom's adult hemoglobin, essentially. This is how the fetus will ultimately get its oxygen. It cannot breathe on its own, and will therefore depend on the oxygen transfer from maternal to fetal hemoglobin. This again is mainly because fetal hemoglobin has a low affinity for 2,3-BPG, so at baseline the dissociation curve is shifted to the left, and hence there is an increased oxygen affinity. Finally, carbon monoxide shifts the hemoglobin curve to the left, decreasing hemoglobin's ability to release oxygen when it gets to needy tissue. This ultimately limits hemoglobin's oxygen carrying capacity because it physically binds the oxygen site with a much higher affinity. This is unlike carbon dioxide, which does not bind to the heme site, but rather to a proteinaceous component of the hemoglobin. Time for a flash quiz. What is the effect of carbon monoxide on hemoglobin? It causes a left shifted binding curve and decreased oxygen binding capacity because it binds the oxygen site.
Let's talk about the oxygen content in the blood. As you know, oxygen in the blood is either bound to hemoglobin or dissolved in serum. Where is more oxygen carried? It's carried bound to hemoglobin. Normally 1 gram of hemoglobin binds 1.34 milliliters of oxygen. You don't need to memorize this. Assuming a normal concentration of hemoglobin is 15 grams per deciliter, how much oxygen would be bound to the hemoglobin? The answer is about 20.1 milliliters per deciliter. It's no surprise the absolute oxygen content of the arterial blood decreases as hemoglobin falls. You're losing your major carrier. However, you won't be able to tell that from the O2 saturation and arterial PO2, which can remain high. So what's a lung disease that can decrease arterial PO2? Chronic lung diseases like pulmonary fibrosis and emphysema can limit diffusion of oxygen and decrease arterial PaO2. Bonus question: what can lower venous PO2 even if you have normal arterial PO2? This is something that you should definitely be doing while you study for boards, and that's getting some exercise. Let's work through this table together. Do you recall from the hematology section what polycythemia is? That's right. It's high hemoglobin levels due to red blood cell proliferation. Let's look at anemia and polycythemia first. How does the hemoglobin concentration change in anemia? Well, the actual definition of anemia is a decrease in RBC mass, which indirectly translates to a decrease in hemoglobin because hemoglobin is essentially what makes up the RBC mass. So in anemia, the hemoglobin concentration decreases. What about the hemoglobin concentration in polycythemia? Exactly. As we just stated, in this condition, the hemoglobin level will be increased because, again, this is a disorder of excess RBC proliferation and thus an excess production of hemoglobin. Now, staying with these two diseases, is the hemoglobin molecule itself affected? No. In both anemia and polycythemia, the hemoglobin molecule itself is still totally normal and functional, and thus it can still bind oxygen with the same affinity. There's just too little or too much hemoglobin present, so the percent oxygen saturation of hemoglobin will be normal. What about the dissolved oxygen? This will also be normal because there's nothing in the serum that has changed, so the same amount of oxygen is able to dissolve into the serum. And what about the total oxygen content? Well, this will follow the same trend as the hemoglobin concentration. In anemia, there simply just isn't enough hemoglobin present, so this will lead to a decreased overall oxygen content. In polycythemia, the oxygen content will be increased because of the RBC proliferation. So what would be different in carbon monoxide poisoning? In carbon monoxide poisoning, the hemoglobin itself is directly modified. So as we discussed, there's less oxygen that's actually able to bind each hemoglobin molecule. So what do you suppose happens to the total oxygen content? Exactly, it decreases. And what about the percent oxygen saturation of hemoglobin? Well, as we know, the carbon monoxide molecule takes up almost all of the O2 binding sites on hemoglobin, so the hemoglobin molecules will all be less saturated with oxygen. However, in contrast to both anemia and polycythemia, there's still a normal amount of hemoglobin present. And again, because there's no effect on the serum itself, there will be normal dissolved oxygen. Let's talk about the oxygen content in the blood. As you know, oxygen in the blood is either bound to hemoglobin or dissolved in serum. Where is more oxygen carried? It's carried bound to hemoglobin. Normally 1 gram of hemoglobin binds 1.34 milliliters of oxygen. You don't need to memorize this. Assuming a normal concentration of hemoglobin is 15 grams per deciliter, how much oxygen would be bound to the hemoglobin? The answer is about 20.1 milliliters per deciliter. It's no surprise the absolute oxygen content of the arterial blood decreases as hemoglobin falls. You're losing your major carrier. However, you won't be able to tell that from the O2 saturation and arterial PO2, which can remain high. So what's a lung disease that can decrease arterial PO2? Chronic lung diseases like pulmonary fibrosis and emphysema can limit diffusion of oxygen and decrease arterial PaO2. Bonus question: what can lower venous PO2 even if you have normal arterial PO2? This is something that you should definitely be doing while you study for boards, and that's getting some exercise. Let's work through this table together. Do you recall from the hematology section what polycythemia is? That's right. It's high hemoglobin levels due to red blood cell proliferation. Let's look at anemia and polycythemia first. How does the hemoglobin concentration change in anemia? Well, the actual definition of anemia is a decrease in RBC mass, which indirectly translates to a decrease in hemoglobin because hemoglobin is essentially what makes up the RBC mass. So in anemia, the hemoglobin concentration decreases. What about the hemoglobin concentration in polycythemia? Exactly. As we just stated, in this condition, the hemoglobin level will be increased because, again, this is a disorder of excess RBC proliferation and thus an excess production of hemoglobin. Now, staying with these two diseases, is the hemoglobin molecule itself affected? No. In both anemia and polycythemia, the hemoglobin molecule itself is still totally normal and functional, and thus it can still bind oxygen with the same affinity. There's just too little or too much hemoglobin present, so the percent oxygen saturation of hemoglobin will be normal. What about the dissolved oxygen? This will also be normal because there's nothing in the serum that has changed, so the same amount of oxygen is able to dissolve into the serum. And what about the total oxygen content? Well, this will follow the same trend as the hemoglobin concentration. In anemia, there simply just isn't enough hemoglobin present, so this will lead to a decreased overall oxygen content. In polycythemia, the oxygen content will be increased because of the RBC proliferation. So what would be different in carbon monoxide poisoning? In carbon monoxide poisoning, the hemoglobin itself is directly modified. So as we discussed, there's less oxygen that's actually able to bind each hemoglobin molecule. So what do you suppose happens to the total oxygen content? Exactly, it decreases. And what about the percent oxygen saturation of hemoglobin? Well, as we know, the carbon monoxide molecule takes up almost all of the O2 binding sites on hemoglobin, so the hemoglobin molecules will all be less saturated with oxygen. However, in contrast to both anemia and polycythemia, there's still a normal amount of hemoglobin present. And again, because there's no effect on the serum itself, there will be normal dissolved oxygen. This is a useful framework for understanding the various scenarios in which not enough oxygen gets to the tissues. There are 3 specific scenarios you need to know about: hypoxemia, hypoxia, and ischemia. First, what is hypoxemia? Hypoxemia occurs when the partial pressure of arterial oxygen is decreased. That is, the oxygen content in the aorta is lower than normal. It can be caused by things that decrease the amount of oxygen that enters the lungs with a normal A to A gradient, such as being at high altitude or alveolar hypoventilation, for example with opioid use, or by things that prevent the oxygen in the lungs from entering the blood, i.e. a high AA gradient, such as in VQ mismatch, impaired diffusion, or a right to left shunt, which could include what? Well, it could be anatomic, like in tetralogy of Fallot, with a ventral septal defect where low oxygen content blood goes out through the aorta. Or it could be physiologic, like seen in pulmonary edema. In pulmonary edema, blood is flowing through the lungs, but all the edema in the alveoli block gas exchange, so blood returns to the left side of the heart without getting oxygenated. So now that we know what hypoxemia is, what about hypoxia? Hypoxia is the condition in which there is decreased oxygen delivery to tissue. Hypoxia can result from hypoxemia, as we just discussed, or it can arise from other factors, such as decreased cardiac output or carbon monoxide poisoning. So here's a question for you. What's the most common cause of decreased oxygen content in the blood in the setting of normal oxygen saturation? The answer would be anemia. This, again, is because anemia is not a problem of oxygen binding. The hemoglobin molecules are still completely functional. It's a problem of hemoglobin loss or production. There simply isn't enough hemoglobin around. And what's the most common cause of anemia? Iron deficiency anemia. most likely secondary to blood loss. In addition to carbon monoxide poisoning, we should also add methemoglobinemia here as well. As you may recall from the methemoglobinemia section, it causes a functional anemia because the methemoglobin does not bind oxygen as well as regular hemoglobin. Finally, ischemia is caused by a loss of blood flow to a particular tissue or organ, and thus the absence of oxygen availability. This can be caused by something that impedes blood flow, such as an embolus, clot, or atherosclerotic plaque. Atherosclerosis related ischemia can lead to clinical coronary artery disease, which is the #1 cause of death in both men and women in the U.S. The progression of atherosclerosis and all of its pathologic changes in the human body will be covered in more detail in the cardiology sections. Ischemia can also be caused by decreased venous drainage, because if the blood can't exit a capillary bed, then no new blood can enter it either.